about nutrition in regard to what we do in what we know from the research and what we do in our clinic. Next slide, please. Today, we're going to talk a little bit about what research shows. And then in the last portion of my talk, we're going to talk a little bit about the stigma of weight for children and teenagers and what we as healthcare providers can do to look at our own setting and what we as consumers of healthcare can demand and request for pediatric patients. Next slide. I have no disclaimers. I'd just like to thank Alicia Mavis. We work closely together at Duke, and I appreciate her support. Next slide. So we want to start and talk about what we know. And like many subjects, there are certain things we know, and there's lots of questions we'd like to answer. This is what we know. Next slide, please. NASH, again, the North American Society of Pediatric Gastroenterologists, Hepatologists, and Nutrition, came up with a clinical practice guideline. And this guideline looked at a review of everything that we know currently from the European community and from the North American community about what we know in regard to treatment. Next slide. And so this 1917 guidelines came up with 3 lifestyle recommendations, and that's what we're currently following. Improvement in diet and increase in physical activity is our first line treatment for all children and teens. We want an avoidance of sugar-sweetened beverages, and we want consistent exercise and activity. We work to increasing moderate to high intensity physical activity as tolerated and to limit screen time to less than 2 hours per day. And this is actually a photograph taken in Durham of our Bull City Fit program, which is our comprehensive childhood obesity program that's associated with Duke University. And this is a photograph of them playing before the pandemic. Next slide, please. Just like Dr. Mavis said, bariatric surgery can be considered in select pediatric patients. The general guidelines for discussion would be BMI of 35 or greater, that they would have comorbidities. And it is a conversation that we have with select patients. And so that's different than many of us thought maybe 10 or 15 years ago. Next slide. So when looking at what the studies have said to pediatric patients, and we're talking about children and teenagers, there have been some recent studies looking at recommendations for a Mediterranean diet. And using a Mediterranean diet with children is a positive approach because we're looking at what foods to add. And so the foods that we're adding go back to the previous talk about nutrition. We're decreasing processed food and increasing real or whole foods with a Mediterranean diet. Next slide. And so when we're looking at a Mediterranean diet, it's plenty of fruits and vegetables in their natural form. It's some whole grain breads, potatoes, beans, and nuts and seeds, again, in their whole form. Olive oil is a primary source of fat. Dairy products, eggs, fish, and poultry in low to moderate amounts. And with our pediatric patients in the clinic, we spend a lot of time going over what's an appropriate portion size. For our younger children, we use the Choose My Plate program, and we're showing their caregivers, parents, grandparents, whoever comes to the appointment with them, what's an appropriate size of food. We're also talking about minimal processing. That's the same thing that was discussed in our first talk today. We want to move away from processed food and move to whole foods. As you can imagine, what lots of little children like would be chicken nuggets and other things that are processed. We're also limiting added sugars and sugary beverages, limiting some limits on sodium, limits on high processed food and refined carbohydrates, and fatty or processed meats. So we're moving toward a healthy diet. Next slide. In a recent study by Jeff Schwimmer and colleagues, they looked at a study with adolescent boys. And so they were looking at 40 adolescent boys They were in the age group of 11 to 16, so that prepubertal to pubertal age, and they put them in two groups. One group followed a low sugar diet. Many guidelines recommend less than 5%, and in this study, they chose less than 3% of daily total calories from sugar over 8 weeks of time. And what they saw when they went back and looked at biochemical markers is the ALT had been reduced in the intervention group from an average of 103 to an average of 61. So looking at low sugar is an important concept in meeting the guidelines of lifestyle modification. And that's something that we work hard at to help families understand sources of sugar, help families understand changes in beverages, and where they can do this. Many of the studies in pediatrics looking at diet have a small sample size. And so we look at these studies, but realize that the sample size is small, but it does give us promise. Next slide, please. We're looking at serving healthy beverages. And in doing that, next slide, we want water as a primary beverage. It's a question that we ask our pediatric patients and their families every single time they're in clinic. How much water are you drinking? Do you take a water bottle to school? With the pandemic, there have been changes in water fountains. And so is there a filling station? Is there a place you can fill up your water bottle a second time? Is water your primary beverage? And it's we also ask about sugar sweetened beverages, but we start off with what healthy things are you doing? And then we gather some information about sugar sweetened beverages. The next slide, please. And I'm hoping that this will work. So I'm going to ask the people who are taking care of our IT if they can click on this hyperlink and see if we can open up Potter the Otter. We'll see if that's possible. So it's not possible to open that up at this point in time. Potter the Otter is my new favorite book. And I'm sorry you can't see it, but if you go online, you can find Potter the Otter. It is a book that we're able to look at in clinic on our computer screens. And with each page of Potter the Otter, the top part is written in English and the lower part is written in Spanish. We have many Spanish-speaking parents in our clinic, and we have an interpreter with us, but we can go through and read Potter the Otter with our smaller kids. And Potter the Otter likes to drink water, and he has friends named Tota who likes to drink soda, and he has friends named Moose and Goose who like to drink juice, and he's trying to convince them to drink water. So I strongly encourage you to look at this book because it's a nice way to have a positive approach when talking to younger children. And we usually get a smile on a face, and that's a good thing when we're talking about diet modification. Next slide, please. Here's Potter the Otter again. Next slide. And one of the things that we've seen, and I suppose everybody else who's working with patients who are struggling with weight gain, is during the pandemic, we can look at our growth charts and our electronic medical record, and we can see a difference from March of 2020 until today. And so we see that, and the studies have shown this as well. This is a recent study that was reported in the Journal of the American Medical Association, and youth 5 to 11 gained about 5 pounds more during the pandemic than the previous time period. So they've looked at the time period and marked the months, and then they looked in 2018 to 2019. During the same period of time, 16 to 17-year-olds gained more than 2 pounds in the previous time period. We've seen this in our clinic. We've seen younger kids gaining more weight, and it doesn't take much to figure out why. They sat at a computer screen for virtual school. There was limitations in parks and gyms and pools being opened at the beginning of the pandemic. There was less time to play outside and more time sitting at a computer screen. So at this point in time, what we're working on, our families in clinic, is We've seen the weight gain. Now let's get back to healthy progress. Let's get back to things that we can work on together. Next slide. And we're trying to find new ways to reach families. Bull City Fit is associated with our comprehensive obesity program for children at Duke, and it can be accessed by anybody. So you guys can look at this, and they have virtual cooking classes, and they also have virtual activity follow-alongs. And so the follow-alongs are short exercises that can be done in a small space, and short exercises that can be done with families. Next slide. There's been a recent study that was published, and the study was done by nurses from the University of Delaware, the University of Maryland, and the University of South Carolina. And they looked at a correlation between bedtime and obesity. They weren't specifically looking at pediatric patients with NAFL, but the study's interesting to look at. So it's not just sleep hygiene. They are seeing increases in obesity with children who have inconsistent bedtime. So it's something to for us to ask in clinic, and it's also something to be asked in primary care, whether that's in a private setting or a health department setting. What time do you put your child to bed? And we know there were disruptions in sleep during the first parts of the pandemic, but consistent bedtime seems to be an advantage in combating childhood obesity. Next slide. We also look at serving sizes, and we spend a lot of time with age-appropriate materials in our clinic, looking at what's an appropriate serving size and helping families and children see that. We use Choose My Plate, which is part of USDA program, and we also use their portion distortion program. We can pull that up in clinic and look at it, and we're just trying to look at what's an appropriate size. For example, you can see here a half cup serving is considered a serving of ice cream, but many cartons now are describing more of 2/3 of a cup. So we are always helping families to look at what's an appropriate serving size. Next slide. So what can I do with the patient in front of me? And I'd like you to join me on this journey. The ideas come from the American Academy of Pediatrics, and they also come from the University of Connecticut, Rudd Center for Food Policy and Obesity. And if you're interested in learning more about that, those are two good sites. Next slide. So that we know that there is a stigma for children and adolescents with weight loss. We know that that's something that they struggle with. We know that there is increased bullying with that. And so what we're seeing is, how can we help patients? And so this was a study, this was a policy statement that came out from the American Academy of Pediatrics. It came out in December of 2017. And they identified that 71% of overweight and obese children were bullied in the last year. And what we're seeing is a stigma around weight can add to health problems, especially in regard to anxiety, depression, and sadness, and can affect quality of life. We find that words are powerful. And so when we're looking at the stigmas associated with obesity and with children, that leads us back to where we are in clinic, and what can we do to combat this, and what can we do to present a positive image? Next slide. This is an infographic that was created by the American Academy of Pediatrics, and it's talking about health consequences of weight stigma, and it's also looking at things that we can do, whether we're looking, as all of us as healthcare providers, whether we're talking to schools, whether we're looking at youth-targeted media, whether we're looking at provider training, and that's how we train physicians, how we train nurses, and how we train other people who work in healthcare settings. And it's looking at what can we say to parents. So this is a national movement. This is an area that can help us with the patient population we're talking about today. Next slide. So what can we do? We can acknowledge our own weight-based bias. It's an interesting topic, and I suggest to you, challenge to you to look at the Harvard Implicit Association test, and you can go in there and they have a quick test that you can take to look at your own weight-based bias. Look at articles from the Rudd Center, that's at the University of Connecticut. Also read articles and look at webinars with the Obesity Action Coalition, and have a conversation with your staff and clinic. What are we doing? Are we leading by example? Next slide. So we want to create a safe environment for patients who are struggling with weight issues. We want to make sure we have armless chairs and love seats in our waiting rooms and exam rooms. We want to make sure we're using medical equipment that can accurately access patients with high body weight. We want to have extra large gowns available if a patient needs to change into a gown. Next slide. We want to use our language carefully. Words matter. And if you look at the choices here, do we say someone's an obese patient, or do we say that someone is a patient with obesity? Do we describe something as morbid obesity, which actually is a little bit of an out of a term that's no longer in favor, and we would more accurately describe somebody as a teen with class 3 childhood obesity, and that would be based on their BMI. Are we describing somebody as non-compliant in our documentation, or are we listing their barriers for success and also listing the strength that they currently have? We find that a lot of our patients in clinic prefer the verbiage of unhealthy weight or high BMI to obesity. Next slide. We also want to use images wisely. So if we're using images to describe what we're doing in clinic, or we're using images to describe what we're doing in brochures, or we're using images that are positive, or we're using images that are showing people active and making positive changes. And I think that's important. Next slide. So we also spend time in our headquarters before and during our clinics, our liver clinics, talking about how can we be positive in what we're saying to young people, and how can we be positive in what we're saying to their parents and caregivers. We think it's important to weigh patients in a private area that allows for confidentiality. I think there are lots of us as adults who don't want to be weighed in the hall and have our weight announced out loud. So we want to be sensitive to that. We give patients who want to be weighed an option for blind weighing, so that way they can turn away and be on the scale and not see the weight. We've occasionally, our ADS or after visit summary in our electronic medical record lists the weight. And so we've had patients who've requested not to have it, and we can mark that out. We record weight without comments, and we give patients the option on whether or not they'd like to be informed on how much they weigh. One of the questions that the dietitian that I work with and I might ask is, today would you like to talk about weight, or today would you like to talk about diet? And I think that helps to give patients some control over all of that, because we want to open up those conversations. And of course, struggling with weight management is part of it. But I think there are days that our teenagers especially want to talk about what they've done positive in their diet. And maybe they don't want to list the weight. Next slide, please. We want to focus our conversation on how to make behavioral changes instead of emphasizing weight loss. We want to stress the benefits of maintaining healthy habits, whether or not the patient loses weight, because we need to keep going even if things aren't going well. And that's been our experience during the pandemic. And we also want to look for referrals to people like myself, registered dietitians, physical therapists, exercise physiologists, and support groups. And especially if there's support groups that are available locally. During the pandemic, we have found sources, like I said, with our Bull City Fit, where we can encourage people to use YouTube and to use other things that will help them on their struggle to get to a healthy weight. Thank you very much, and I'd be happy to answer any questions.